Welcome, everyone, to our very first webinar for Universal Healthcare for Colorado Now. I am Senator Jeanne Nicholson and host for today's webinar. I'm a retired public health nurse and served in the Colorado Senate from 2011 to 2015. First and foremost, thank you for being early and loyal supporters of universal health care. We have come a long way on our journey together. It might be tempting for some advocates to give up, but the secret to winning is to have a good vision, be able to communicate the vision to others, be persistent, and never being overwhelmed by mistakes. Number one, universal health care is a very good vision. You and I are spreading the word across Colorado about the universal healthcare concept. We won't give up, and we are not overwhelmed by previous campaign mistakes. We meet all four criteria of a successful campaign. So today, because of your collective persistence, we are here to tell you we're making progress. 30 organizations have joined the coalition to support a better way to pay for health care. The Colorado legislature passed the health care analysis bill, and the governor signed it into law. With your help, we raised $750,000 to pay for the analysis. Right now, the Colorado School of Public Health is working on the analysis, and a recent Colorado poll tells us Colorado voters know our current healthcare financing methods are not working to assure us of affordable, comprehensive healthcare for all Colorado residents. I'm pleased to introduce our two speakers for today's webinar, Kiera Hatton and Virginia Gebhart. Kiera will begin with a personal story that motivates all of us to fight for universal health care. Virginia will follow with her personal story and provide details about the School of Public Health analysis. Kiera will follow Virginia again with reproductive freedom campaign story, and then I will describe our strategic plan. And finally, Virginia will be describing how you can help us achieve universal health care in Colorado. We'll leave 15 minutes at the end for questions from all of you and answers from us. Our next webinar, I'm pleased to announce, please put this on your calendar too, will be about moral injury, Thursday, June 4th at 6 p.m. Please join us June 4th for our next webinar. So for now, take it away, Kiera.
Thank you so much. My name is Kiera Hatton Sena. I'll tell you a little bit more about my professional career in my next section. But for now, I wanted to start with something that's really personal. It is unfortunately not that unique. My family has been navigating the healthcare system for most of my life. In 1997, my father had a double lung transplant. It was a terrifying, complicated, and life-saving procedure that was not covered by insurance as well as it should have been, leaving my family in some financial distress. Even then, there was a sense that somebody was actually coordinating the system and it was hard, but it didn't feel completely broken. Years later, I had an emergency C-section, and I learned that what it means to need urgent care in a system where coverage, communication, and patient protections are not guaranteed. This was prior to the Affordable Care Act, and so I was also saddled with massive medical debt starting my adult life. But now my sister is facing major medical issues. She is nonverbal and disabled, so she cannot advocate for herself. Um, she has been facing these issues over the course of about most recently had an injury in early March, and we've been navigating these issues. She needed a feeding tube and lots of other medical care. But what I was astounded by as somebody that works within this system was to find how much We experienced delay, confusion, and this constantly feeling that our family had to piece together what was actually happening. It felt not like a care system and very much like a maze. And I want to be really honest with everyone about what moved things forward. My solution, when I was so frustrated that I was scared she was going to die, was to send an email to my personal network, which includes a lot of medical care, medical providers, lobbyists, and people who know how to navigate these really constant systems under pressure. I was able to get her action and a feeding tube within 24 hours that we hadn't been able to access for over 9 days because I had access to a network of people that control power, not because the actual healthcare system worked the way that it should. And that should bother every one of us. Not because, and it, not everyone has this network. Not everybody knows who to call, what language to use, how to escalate a procedure, or how to fight within a system that is fragmented and get them to pay attention. When people need coordinated, timely care, we shouldn't be having to use our personal networks to make it happen. The system should be working for us. For me, this is not about one bad experience. It is about a healthcare system that has become harder to navigate, incredibly expensive, and much less accountable to the people that it is supposed to serve. When the system is this fragmented, people get hurt, and worse, that the people with the least ability to fight their way through it are the ones most impacted. This is why universal healthcare matters. It's about freedom, it's about common sense, and it means that you are able to get the care when you need it without your health depending on your job, your income, your zip code, or your ability to argue with insurance companies and medical providers in systems that are not designed to protect patients. We're already paying for healthcare. We pay it through premiums, deductibles, copays, medical debt, delayed care, surprise bills, and our taxes. The question is whether we keep playing into a broken maze or we go build a system that works for everyone. This is a chance to stop accepting a system that forces families to become case managers in crisis. It is a chance to build one where care is universal, coordinated, affordable, and humane. A system where care is not a maze, where urgency does not depend on who is in the room asking questions, where no one is disposable, and where healthcare finally means getting care. So I'm going to ask you to support the work that we are all doing together, and I look forward to telling you a little bit more about how we can get there by mirroring some of the work I've been able to work on in the past. Thank you so much, and I'm going to pass it over to Virginia.
Unmute yourself, Virginia.
Thank you. Okay, thanks everyone for joining us. I'm honored to be speaking to you today. Doing this work keeps me grounded because I get to work with incredible people like Kirby, Kiera, and Jeanne, who share my values and who believe we can do better. I'm Virginia Gebhart, a retired pharmacist. I graduated from pharmacy school in 1975, worked in community pharmacies for about 20 years. In those days, health insurance was pretty simple to understand with very low copays of $0 to $1 or $2 for each prescription. We could fill prescriptions ordered by a doctor with zero interference from insurance companies. There were zero prior authorizations. Needless to say, things have changed. Pharmacy benefit managers, or PBMs, have grown to become powerful and clever middlemen. They come up with every scheme, scam, and trick in the book, and then some to cheat us. They created prior authorizations to delay and deny payment for your medications in order to pump up their profits. I'll share my son's story. My son, Michael, received a liver transplant in 2007 at the age of 17. He got excellent care at Children's Hospital. He got good coverage from our health insurance. It was easy to get his prescriptions filled locally for reasonable copays. Flash forward a few years, and he was suddenly forced to go through specialty mail order pharmacies. Turns out their specialty was the worst customer service in the history of the profession. Then they required prior authorizations every 6 months for his anti-rejection medication. He has to take this every day for the rest of his life. Then they just stopped covering his medication altogether. He has to pay out of pocket for it now. My son could never understand why they made it so hard for him to get his medication. I had to explain to him that they were trying to lemon drop him. They wanted him to drop his current insurance and get insurance from a different company. Trouble is, they're all racing to the bottom. I'm so angry at the way the insurance companies and PBMs mistreated my son. I know this sort of thing goes on every day, all day long, all across the country, affecting millions of people. Even people with insurance are facing these real barriers to care. Patients like my son, doctors, nurses, pharmacists, mental health professionals, we all feel like cogs in a massive money-making machine. In fact, many doctors are experiencing moral injury because they are unable to provide the care they know their patients need. They're trying to do their jobs inside a system that places a crushing administrative burden on their backs. There are endless roadblocks to providing good care. This insurance system is not working for families, and it's not working for healthcare professionals either. I follow my hero, Wendell Potter, on Substack. Many of you know he is a health insurance executive turned whistleblower. His recent Substack was titled, "Why Are More U.S. Doctors Moving to Canada?" He reported that the Medical Council of Canada said the number of American doctors taking the first step to being licensed in Canada has increased more than 750% over 7 months compared to the same time period the previous year, from 71 applicants up to 615. Why? Because they can't stand the crushing administrative burden, the prior authorization, the denials for care. They can't tolerate the weaponized complexity and high cost of corporate health insurance in the US. They want out. So what can we do? We have an opportunity to do a better job right here in Colorado. Many of you know we have been working hard to pass SB 45, Healthcare Payment System Analysis. This bill, now signed into law, directs the Colorado School of Public Health to analyze draft model legislation for a state-based universal healthcare payment system for Colorado. A large and growing group of allies has been critical in the success we've had in passing this bill. I'll drop a link in the chat after I'm done talking so that you can see a one-pager that has a partial list of all of these allies. As you know, the state budget has been tight for years, so we agreed to fundraise the $750,000 for research by the Colorado School of Public Health. Through a months-long grassroots effort, we got it done. Their report is due by the end of this year. The groundbreaking research they're doing will follow up on research they did for HB 191176, Healthcare Cost Savings Act. This follow-up research now will be at a more detailed level. It will look at draft model legislation and will show us how shifting to state-based universal healthcare payment system would affect each of us, our families, our communities, and our state. It will answer important questions like these. Will it be affordable for me and my family? Will it be equitable across all areas of the state? Will it cover everybody? Will it cover nursing home care? Will it cover home care for seniors and people with disabilities? Will there be copays and deductibles? Will businesses save money? Will people be free to start their own businesses without fear of losing health insurance? How are we going to pay for it? The answer to these questions and more will help us understand what kind of healthcare policy reform is possible. There's a webpage dedicated to this project, and that's another link I'll drop into the chat when I'm done. If you scroll to the bottom of that webpage, you can see a recording of the first analysis collaborative meeting starting at minute 58. In the video, you will hear directly from the brilliant research team. I guarantee you will be inspired by the research team and the nature and scope of their work. We hope their research will support our goal of a state-based universal healthcare payment system, But what if it doesn't? It will still provide important data to inform future policy decisions. The platform they've developed to do this analysis allows them to plug in different variables and see how they ripple through the system. For example, they will model different payment levels for doctors and hospitals. Would current Medicare payment rates be enough, or would double the rates of Medicare be better? Would rural hospitals need a different payment rates? Can we find ways to make billing simpler and more efficient for everyone? If the analysis does support our goal of the state-based universal healthcare payment system, we'll work together toward a ballot measure in 2028. Then the people of Colorado can vote on this. Wouldn't it be great if this healthcare payment system analysis leads to simpler, guaranteed healthcare for all, so that we could attract doctors to come here to Colorado instead of moving to Canada? I think we've got what it takes to make this happen. What do you think? Thanks.
Thanks, Virginia. And Kiera now will present to us the successful story of the Reproductive Freedom Campaign that she was a very big part of. So we know this can be done. And now we have an inspiring example that we can follow.
Hello again. In my professional life, I am the political director of COBALT Advocates, and I'm going to tell you a little bit more about our organization. During the time of the campaign, I was both political director and organizing director at COBALT, and so I got to work all the way through this campaign in different areas. And so I want to talk to you a little bit more about what it takes to make a campaign work, what it looks like on the ground, and how we build that power that we need to succeed and implement the passage. So these are lessons from Amendment 79. Amendment 79 was the campaign to add the right to abortion and allow for public funding in the state constitution. And I do want to tell you a little bit about COBALT so you know who we are. We were founded in 1967, and we are a comprehensive reproductive rights organization that includes an abortion fund. We operate an entire set of entities that together make up our organization: our C3 Foundation, our C3 Abortion Fund, and a Practical Support Fund. We also run a C4 political arm with a solid record of policy and political wins, including independent expenditure committees, PACs, and all of those things. Contributions, though, to our abortion fund and practical support fund are 100% directed to care, and they are the only independent funds of their kind here in Colorado. We believe that nothing should ever stand between you and your healthcare decisions, which is why we are really deeply dedicated to fighting for systems, structures, and policies that protect reproductive rights and guarantee comprehensive universal access to reproductive healthcare. We believe that this extends to advocating for universal healthcare so that everybody can experience the quality of care we do with reproductive healthcare in every aspect of their lives. We work to pass policy that protects and expands access to reproductive care that does include abortion. In 2022, prior to the Dobbs decision coming down, overturning Roe v. Wade, we passed the right to abortion, the Reproductive Health Equity Act. We did that because we knew things were shaking out poorly at the Supreme Court, and we wanted to make sure Coloradans were protected. In 2023 and 2025, we passed some shield laws that protect patients and providers, because every state in our country is different now, and we need to make sure that we do this work well. We made sure we passed emergency medical protections so that everybody going into a hospital, regardless of ability to pay, immigration status, or need for reproductive health care, can have access. And in 2025, we passed the implementation of Amendment 79, because we know that when you pass a ballot measure, it doesn't end there. We have to make the legislative and rulemaking fixes to bring it to life. We did co-chair the campaign to pass Amendment 79. That campaign occurred in 2024, and we passed with 62% of the vote. That is groundbreaking victory and an incredible amount of work. I'm going to take you through what that work looks like, but there's a little bit that happens before this timeline I'm about to show you. So we're going to start a little bit before 2022. Here is a snapshot of our campaign that we worked on, Coloradans Expanding Reproductive Freedom. So this timeline really starts in March of 2023. But I want to take you back before that. This campaign really started at the end of 2020 when we had just defeated the ballot measure 115. 115 was trying to restrict access to abortion. We knew that we had to do something to protect it, prevent future ballot measures like that going forward. And so we started building all the groundwork so that we could create a groundswell of support and then run a campaign. Our very first campaign leadership began in March of 2023. We convened our policy partners, research and legal teams for that first policy stakeholder session. Those are tremendously boring, involve a lot of attorneys talking to each other and arguing, and a whole lot of polling data. We spent 6 months in that process trying to get the title exactly right. And we got a title that not only was perfect, but it was far more than we could have ever dreamed of. It managed to pass single subject, even though it included 2 unique items. One was the right to abortion, and the second was the ability for government to pay for abortion because we had to repeal a public funding ban. We spent all that time getting the right language, and that is so very, very important in this process, and it cannot be skipped. In September of 2023, we did file that title and text with the title board. The title board is a unique entity that you have to navigate through and it's a legal process of their own. You have to be measured on single subject, whether your title fits a whole lot of categories, and that includes naming our designated representatives that represent us there. We were lucky to have an amazing team of attorneys, many of which I'm sure that you all get to know quite well. And then in November 2023, something kind of unique happened. We had planned our timing to experience motions for rehearing and create all these timelines. So right before Thanksgiving in 2023, we didn't expect to get approval on our title until late December or early January. But our opposition chose to not fight us, which left us in a really unique position and quandary. Because we got petitions right before Thanksgiving, and nobody wants to be petitioning during Thanksgiving, and nobody wants to be petitioning over Christmas break. And so we launched a program at a time where we really lost 6 weeks of our ability to petition as effectively as we could have, because lots of people take vacation, rightfully so, and want to celebrate the holidays. And then in January 2024, we officially launched the public face of our campaign. We did this in 6 locations over the course of a day and a half. Denver, Grand Junction, Greeley, Montrose, and Boulder. The key to our success was in part statewide engagement. We did this work early. I began that work actually in April of 2022 with my organizing team at COBALT. And we built some of this really unique groundwork and ran into people that I already knew but got to get reacquainted with, Kirby, who's on this call, Gwen Unger, and many others. And then in February 2024 is when our partners really hopped in. They helped us. We created 27 statewide petition hubs, and we were working all the way through this process. We had a paid field team. We also had a massive volunteer team with over 100 volunteers. And we were actually able to get all of our volunteer signatures in Senate District 35, which is one of Colorado's geographically largest and most rural districts, all by volunteers. Thank you, Kirby. Can't do it without you. Kirby is an amazing petition hub leader. And having those different petition hubs created a system in which people knew where they could go to both pick up and drop off. They could get their petitions notarized. We ran an incredible notary program so that all of this collaborated so that we built the voice of a campaign all the way through the collection process. In April 2024, we were able to submit for 225,000 signatures. It is just shy of a Colorado record. We probably could have gotten there, but we might have had to turn in some petitions that were bad, so we didn't do it. And then in May of 2024, we found out for sure that we were announced sufficiency. We didn't have to go collect any more signatures and found out our initiative was on the ballot. This is a long process. It is tedious, and I as difficult as campaigns are and petition processes are, I highly recommend them because you mean you're talking to voters all the way through. You get to talk to people all across the state and you get to raise and build support. And the people that carry petitions remain some of our best supporters at COBALT today. They're showing up at our gala on May 2nd. They are making donations. They are engaging with us, and they can't wait to engage with us on whatever we choose to do next. And I'm standing here in this room telling you I want to bring them with me. By August of 2024, we had raised $13 million in support of this ballot measure. We did that with groups like you. Many of you on this call are our individual donors. It took a ton of time, effort, lots of people, and really amazing fundraisers to do this who are still with us, and I hope that we get to continue this work together. And then in September of 2024, we finally received our official ballot number. This is one of the things that surprises people. You don't actually get your official ballot number for a while. So you can't print your materials, you can't do all of these things until just a few months before the election. That contain your ballot number, which is why we often don't run a yes on 79 ballot measure. We run something that has a title like Coloradans Expanding Reproductive Freedom. Then we moved on to election day. These volunteers came with us all along the way. They knocked doors, they made phone calls, they continued to contribute financially. And because of that work, we were able to get 62% of the vote. What I think is even more astounding is we won all 8 congressional districts. That includes Lauren Boebert's district. That includes my home district with Jeff Hurd. That includes Jeff Crank's district. That includes Gabe Evans' district. So people all across the state stepped up to say, we want health care, we want abortion care, and we want to pay for it. So we have data that says that health care wins on the ballot, health care delivers, and it also turns out extra voters to the polls. Those are all really amazing, good things. But the work doesn't end there. We won. It feels so exciting. On election day, I could hardly believe we won by the amount that we did. And I'm so honored that I got to do that work. But where I really think that some of the work actually begins is when you win. And so starting in July of 2024, before we won, I started working on policy at COBALT to make sure that we could implement it and get this care to people as quickly as possible. Because it doesn't end the minute you win an election, no matter how much you want it to. The work still continues. So we wrote a bill with some amazing bill sponsors, SB 25-183, which is Medicaid funding for abortion, which allows Healthcare Policy and Finance Department of the Colorado government to implement what we passed in Amendment 79. And that work really began before because we set rates for providers so that they could be sustainable on government funding. And so we have the highest rates for abortion and some of the highest for reproductive health care in the country because we fought for those. And we can continue doing that across all of healthcare when we can pass this ballot measure and free up spending so that we're not spending it on insurance companies, we're spending it on people and care. And then we bring people into the system and we bring providers into the system and we give them hopeful, wonderful care. That leads us to current efforts. Medicaid covers abortion care in Colorado. We had been excluded for years and years, but there are still things that are complicated processes. So we know that our providers need help. So we brought in an organization called Clinic Revenue Partners to make sure that all providers understand how these complex billing processes, administrative requirements, and concerns about reimbursement rates that have sometimes discouraged people from participating in the Medicaid and at some point universal healthcare system are no longer excluded and they're no longer discouraged. And I'm so proud to announce that we were able to get all but one independent abortion provider enrolled as a Medicaid provider. And the one provider that did not enroll as a Medicaid provider didn't do so because they only do 7 abortions a year. And so we think that that is okay. And so we are preparing clinics for success, and we can prepare all providers for success by continuing to make sure that we do this work right and we do it holistically. Because there are groups that'll come in and make sure that people can enroll in the system and make sure that we are working with providers to get them the rates they need to deliver quality patient care so that patient care is deeply accessible, that we start expanding and that we're not allowing for these deserts. One unique thing through all of this work, Colorado has actually attracted providers. We know that we have more OBGYNs in the state now than we did 3 years ago at the fall of Dobbs. In tough times, we have attracted people to our state. We are creating increased enrollment at our medical schools because we allow for full expansion of reproductive health care. And by continuing this process, we can actually allow Colorado to become the hub of healthcare in the country if we can work to pass universal healthcare. Which is why we are here. We are standing in solidarity with our partners. All of you stood with us. You helped back our ballot measure. You helped get us on the ballot. We know that this was one of the things that stood in your way in prior iterations of looking for universal health care. So we stand here in partnership with you to pass universal health care in 2028. And I look so forward to working with everyone here. And if you'd like to contact me, I will also drop this in the chat, but I wanted to make sure that you had my email and you are always welcome to contact me at any time. So thank you so much for your time. I look forward to partnering with all of you, and I'm going to pass it on.
Thank you, Kiera. That's so inspirational for all of us. It gives us this pathway to what we need to do with our strategic plan. So next, I'm going to talk about our strategic plan, beginning with, of course, thanking Kiera and her whole team for providing a great deal of information to us about how to create a successful strategic plan. And so from the very beginning, we have created a strategic plan for universal health care for Colorado now. Our goal is to provide high quality comprehensive health care for all Colorado residents that each can afford. Throughout 2026, our plan is to educate voters about the problems with our current financing methods and help them envision better ways to pay for health care. If the Colorado School of Public Health determines that a universal health care plan is financially feasible when they complete their analysis December 31st of this year, we plan to educate voters and elected officials about the results of the Colorado School of Public Health analysis in early 2027. We will poll Colorado voters to learn their views on financing healthcare using a publicly funded, privately delivered healthcare plan. We want to win the support of at least 1.9 million plus one voters in Colorado. There are 3.8 million active voters in Colorado. So in order for us to achieve a simple majority, we need to get the support of 1.9 million plus one voters. And we want their support about the benefits of one nonprofit, publicly funded, privately delivered health insurance plan for all Colorado residents. Not just in general a universal health care plan, but a very specific idea of how it would be financed. Next, we want to educate city councils, school boards, and county commissioners. Encourage them to pass resolutions in support of a publicly funded, privately delivered nonprofit healthcare plan. A few county commissioners in Colorado and city councils have passed resolutions, but we need support from many more. Also, we need to lobby the state legislature and governor to pass a bill in 2027 during the legislative session to place a measure on the ballot in 2028. We need to continue to build a strong coalition of Colorado organizations supporting universal health care. As I mentioned before, we already have 30 organizations that support our efforts, including the Colorado Dental Association, the Colorado Nurses Association, Family Medicine Practice Docs, and others. But we need more organizations to support our efforts. And we need to raise at least $15 million for polling, for a professional campaign manager, professional fundraiser, professional field organizer, professional marketing expert, and legal counsel. We need to support national legislation to remove barriers to state-based, publicly funded, privately delivered health care. And we need to create a transition team like Kiera was talking about for the Reproductive Freedom Act, to be ready to implement a nonprofit, publicly funded, privately delivered health plan. And finally, to pass a ballot measure to publicly finance a health care plan for all Colorado residents. And to do all this work, we need all hands on deck. Virginia now will tell you how you can help.
Thanks so much, Jeannie, and thanks, Kiera. Here's what we ask all of you to do. Please consider being a county healthcare champion in this movement as we educate Coloradans about what state-based universal healthcare could mean for Colorado. Thus far, we have 30 in place. Can you be a healthcare champion in your county? Also, please talk about this healthcare payment system analysis with your current electeds and candidates during this campaign season. Let them know you expect them to act on the results of the report to inform healthcare policy in the next session. Speak up about this at town halls and fundraisers. You'll be educating the candidates and the other people in the audience too. We have an opportunity to do better here in Colorado, and the candidates have an opportunity to be leaders in this growing movement. Your advocacy matters. Smart electeds and candidates do listen to their constituents. We need to gear up for taking action when the analysis is completed. And as you know, it will take substantial funding through donations to get a ballot measure passed. We're gearing up now to receive your donations soon, and you'll be hearing from us when we're ready to receive those. And thank you for the work that you are already doing and what you're going to be doing going forward. We can do better when we work together. Thank you so much.
Thanks, Virginia. At this point in our presentation, we'll open it up for questions from all of you. And Kirby, perhaps you can kind of guide us with what those questions are and we can respond.
You'll see two in the chat. That's all I'm seeing so far. You see them?
If you'll just read them so everybody can see them, that'd be great.
Sure. Alessandra said, seniors are on Medicare, a federal program. How does a state-based system work for them? Great question.
The state-based plan would draw down through a federal waiver the Medicare funds so we can include Medicare enrollees in the Colorado Enterprise Plan. In addition to that, if it is financially feasible as determined by the Colorado School of Public Health for us to include long-term care, we will add that as a Medicare benefit. And we also intend to cover vision, hearing, and oral health, which are not basic coverage benefits for the traditional Medicare plan.
Thanks, Jeannie. I'd like to add a little something to that, if I could.
Absolutely.
Something that all of us can be doing now is urging our members of Congress to support the State-Based Universal Healthcare Act bills that are in both chambers of Congress, and they have been for a couple of sessions now. Ro Khanna of California is the prime sponsor for the one in the House. And this is meant to specifically to make it easier for states like Colorado and all of the other states who are trying to do what we're trying to do, make it easier for us to receive those waivers and get those federal dollars that are already flowing into the state and let them go to our single payer system.
Thanks, Virginia. Kirby, what's the next question?
Yeah, great question. Jan Phillips asks, would you try to make this an amendment to the Colorado Constitution to embed it so no matter who our legislators or governor is, it's protected? Another great question.
Well, the answer is that is not the plan that we have in mind because it is so much more difficult to get a amendment to the Constitution passed. It requires a higher percentage of voters and a support from all 35 Senate districts, requires signatures to be collected. So Plan A is to get the Colorado State Legislature during the 2027 session to pass a bill that would be signed by the governor to put a measure on the ballot in 2028, asking the voters if they would pay a premium for a single payer healthcare plan in Colorado. If that bill does not pass, then we will move to Plan B, would be to put a measure on the ballot that would be not a constitutional amendment that's locked in, but would not require as much money or volunteer support to get it passed. If that doesn't work, then of course we would go to an amendment to the Constitution. But because of the path to an amendment constitution being a very big challenge in terms of the number of voters, where the supporters have to come from, and the cost, we want to start with Plan A, which is to try to get our Colorado legislature to put a ballot measure on the ballot in 2028. That doesn't mean there wouldn't be a lot more work to do after the ballot measure is on the ballot. It would simply mean that our efforts could be focused more on getting the ballot measure passed without having to collect signatures or raise as much money. And Virginia and Kiera, please add to those comments.
I think we have a question.
I think you've covered it. Something that I would add is that this is a really complex topic, and I think we've learned in the past that complex amendments to the Constitution can be problematic, and things are evolving in healthcare, not even to mention AI, that who even dreamed of AI being an issue in healthcare even a few years ago? So that I think statutory is far more attractive to me because this is such a complex and large subject.
We have a question
I
from,
don't really have anything to add.
sorry, Karen. Okay. Well, we do have a question from Amy and Marta.
I guess I didn't quite understand Jeannie's answer just now, so I just want to ask a clarifying question. So you're saying this would be a statutory, we're trying to get our state legislators to put this on as a referred measure, is that right? And you said the question was, would you be willing to pay a premium for single payer health care? That would be the question you'd ask the voters later. And to me, I think most people understand what a premium is, but would people think, would you be willing to pay for a premium in addition to what you're paying now? Or how is that all going to be explained?
Thank you for that question. And it is important for us to really delve into the details. So the reason I mentioned that it would be a premium is that legally and politically speaking, it is far better for us to talk about this being a premium than a tax. A premium is for something very specific that the voters have told elected officials they want their money spent on. A tax is something, it's funds that the elected officials can spend on whatever they think is most important for their constituents. And it's not earmarked like a premium. And because we know tax among some people is a politically charged word, and immediately people don't want to support a tax increase, we think that it is honest and legally accurate for us to describe this as a premium rather than a tax. And the next part of your question is very wise on your part. I'm suggesting just conceptually what the language might be. I don't know exactly what the question will be on the ballot. And the reason is because I'm not an expert in the right language for the ballot. That was what Kiera was talking about earlier, where you get a team of expert attorneys whose whole careers have been in determining exactly what that language should be. And they will advise us prior to us even going to the title board about what that exact language should be. I'm not sure if that answered all of your question.
Well, I think it answered my question at this early stage, but my experience in working with lots of voters over time is that a lot of voters don't understand ballot measure questions. And it takes a lot of explaining to have them understand that. So I think a lot of them end up being as clear as mud once they reach the ballot. And I think it's really important, especially to pass something like this, which I think so many people would be interested in, to have it really make sense when we get there. And we need to think like beginners, like that we don't, because most of the people in this meeting probably are not beginners. We have some investment already in this. And so we understand a lot more about it than people who were going to reach out to as voters. And so I think we need to make it for them something simple that will, as Kiera mentioned, also help bolster turnout at the polls, because this could be good for several reasons. One, I'm so for this, but two, for a high voter turnout too. So
then I feel we need to outreach the Latino population. Our immigrants are Latino. We don't have them. We need a lot of more pepper. I mean, I'm one, but I can do whatever, but we need to encourage them. And it's not that we don't encourage them. They don't know. They don't understand. They need to be explained, what is this going to benefit? Our farmer workers and all that, they have families. They could benefit from this. I can see all of them buying into it. Small business that have families, that can afford it. So they would be great. And that's a big, big outreach that I can be part of it, but I can't do it myself.
Also in Spanish. We need
Yes,
to have materials in Spanish. Yeah.
That is exactly why at the end of our presentation, we said we need all hands on deck. We need people like you who are sharing this information because you truly understand the importance of the changes we need to make, but you also understand how to communicate to different populations in the state so that we get the communications as clear as possible to everyone. So thank you very much for participating, and we are signing you up to be on the campaign trail to volunteer and help us communicate as clearly as possible to all of these people that we need to reach. So, Jan, Phillips has her hand up.
Yes, thank you so much for explaining all that to us. And I definitely understand your idea about not making an amendment, although having Kiera here, I thought that was maybe the direction we were going in. But I will just say my opinion is the word premium is almost as loaded as tax. And if there is any other term we could potentially use besides that word, especially these days with it shooting up exorbitantly high, I think that's just not the best word we could choose for explaining it to people. It's just my 2 cents.
You know, I appreciate that, Jan, and I think that that's why we need to contract with some communication experts who aren't so close to the issue as you and I are, all of you, but who are very good at knowing what trigger words are that either offend people or engage people, and help them to give us some advice about what the word should be. I'm pretty confident the word shouldn't be tax, but we probably should find a good word. Virginia and Kiera, do you have anything to add?
I do. We actually spent, I mentioned this, and I could go back in the slides if I need to, but we spent 6 months trying to get this language right. It is actually the single longest phase of our campaign. And there is a boring, horrific methodology to make that happen. And we've gotten uniquely good at it. And we're helping others do that now. And so I think we spend that time and we take the time to get the language right. And right now we are talking in terms that everybody does not understand, but we will get them to that common sense language that we can communicate with everybody. We can do the translations we need. I work with an amazing translation company on everything I do at COBALT called Album. Highly recommend them. They are both, I can't speak highly enough about them because they can both help with technical terms in short and long-term programs. So highly recommend. But making sure that we communicate clearly about health and health equity and our move to have universal health care and a single payer system here in Colorado is so very important. So taking the time to do that. But I also do want to shout out, and I don't want this to sound like I'm just constantly fundraising, but I feel like I'm constantly fundraising, is that polls are expensive. Attorneys are expensive. And so bringing the people, a standard poll is $25,000 to $40,000 each time. You want to do a couple rounds of those. You hire attorneys that their billable hours shock me every time you see them. These are intense expenses. They're also really doable. They sound high. But what you get by doing the work returns so many benefits, and it means that you get the language right. It means you talk to voters clearly, and it means that it makes your campaign easier because you're not pushing back on false narratives. You're not pushing back on language that people don't understand. And so we can do this, and it is a simple process, but it is not necessarily easy.
Thanks, Kiera. Virginia, do you have anything to add?
Nope.
All right, Monica, you have your hand raised.
Hi, you guys, and sorry I've been off video. I'm having dinner with my kiddo. So great to hear these conversations and hear from some folks who I've known for a while. I started my healthcare career in Massachusetts when they expanded their version of universal healthcare, and you guys are talking about exactly the right things. Health literacy amongst folks, reaching very diverse populations. And I had the great fortune of sitting on the Healthcare Cost Commission with the 1174 Bill Colorado 1174. And one of the things we found, because we did surveys in town halls in both English and Spanish, one of the barriers we found is that for our Spanish-speaking population, they said, I don't care if I have access to healthcare, it will still make me sick because the system is racist. So I love that you guys are thinking about incorporating populations early enough to make those design decisions so that it serves everybody. And it's not just the same system, but with a different payer. I joined tonight because I wanted to hear how the conversation was, what you guys were talking about, because I'm currently running in House District 9. And so as part of the strategy was to talk to candidates, I just wanted to know if there's anything specifically I as a candidate should be hearing from you while I am on the campaign trail. So that's mostly the question is, what is it that you want candidates to hear? We talk amongst ourselves a lot. And so happy to, carry back messages to other folks.
Virginia, would you like to respond to that?
Yes, I would. I would like to hear that electeds will actually look at this and read this report. The 1176 report was released, and we thought, wow, this is great. It shows that a single-payer universal healthcare system has the potential to save up to billions of dollars a year in Colorado, and we got zero response from anybody. We got crickets. And so what I would like candidates to do, to pledge, and electeds to do, is to actually read the thing and develop what's possible. We don't know what the report is going to say. We hope it's going to say we can go forward with our plan. And if that's true, we would want people to jump on that bill and co-sponsor that bill and help us write it so that it's something that you can support and that meets our goals.
Kiera, something to add? Advice for candidates?
Well, one, I always have advice for candidates, but one of them is to actually do what Monica just did right now, and that is show up in spaces that, might align with your values or might not, so that you can hear what people are saying and the work that is coming. So first of all, thank you for showing up. Hugely important. If anybody else is a candidate, please wave your hand so I know you're here, because it makes me want to support you even more. And I think the other thing is also to, as we navigate these, there's lots of groups in this room. Every single one of these groups are groups that can both help a candidate in their campaign. They are people that can help win elections. So some of it's talking and stakeholding with groups. And I think that's one of the things we see that is problematic at the Capitol, is that many legislators do live within bubbles. And so we want them hearing from lots of people and doing this work. We've seen lots of great bills fail this year because they were not properly stakeholded. And it's so sad, because our state would be better had that work been done on the front end, which is why we're out here doing the work on the front end in 2026 to get this work done. So that's kind of my 2 cents. There was another question in the chat, though, that I'm worried is going to get lost, specifically by Sonia. Can I go ahead and grab that one?
Of course.
Cool. So the question is, how would you convince people who do not pay now because they have corporate coverage? In most cases, people that have corporate coverage are also paying a substantial portion of their own payment. So they're feeling that in their pockets right now. But one of the things that actually brought me back to this work was I was strangely at a funeral, and somebody was asking me, when am I ever going to go past universal health care? Because they knew it's been a passion of mine for a long time. And they put that question out. This person is the CEO of a large energy corporation. And I was astounded. I was like, wait, what? Why do you want to do this? And the answer was, he said, one of the costs that I cannot contain is the cost of healthcare. It means that I cannot pay my union workers more because we spend so much time negotiating health benefits that we can't negotiate wages. This is a staunch Republican who is the CEO of an energy company. So I think that this work is key to one, we bring in business, we bring in individuals. The people that are not going to like it are the insurance companies, and they can feel how they would like to feel about it. But I think we need to be doing outreach to chambers of commerce, small business, big business. We work with our labor unions to talk about how nice this would be if we could pull this out of their negotiations so that they can negotiate on other benefits. They can negotiate on having high 401k contributions. They can negotiate on having the highest wages in the country. They can negotiate all of these other avenues, including worker safety, benefits, vacation time. But right now, and my husband is a steelworker, every time his contract comes up for negotiation, the sticking point ends up being healthcare because they want healthcare 100% paid, but it means you get hit on wages. And so the wages take a hit, or these other avenues take a hit. So we have all these cool places where we have shared values, and we might be coming at it for a different reason. Corporations might be doing it to save money and individuals are coming at it for different reasons. Labor unions should come at it for different reasons. But when we spend this time to go build those networks, we can get this done. And so some of those, and I'll throw it out there. The thing that I want to know from all of you is who is in your network? Like, who do you know that is in HR or leadership at a company? I want to know who you know that is in labor unions, whether they're a basic member or whether they're a leadership. I want to know all these things from you so that we can use them to build out this program.
Thanks, Kiera. Amen to all of that. And I would add that not only are you paying your health insurance premium, or your employer is paying it for you, or you're paying a percentage, but you're also paying a lot of money through your taxes to cover other health insurance plans. For example, people who work as public employees. All of us pay taxes to pay for our public employees to have health insurance through a private commercial healthcare company that is charging us more than we need to pay if we change to a single payer plan. So it's not just those hidden costs that you might not notice because your company is paying for your health care. It's also the taxes that you're paying. For the people who, for example, were part of the health exchange and are buying their healthcare plan through the exchange and being provided tax credits, we're paying for that now as well. So those are responses that we can make to people who think that everything is fine because they have health insurance coverage through their employer, and that they don't realize that their plan is costing them far more than it needs to cost them, because right now they are paying for advertising, they're paying for lobbying, and they're paying for very high CEO compensation packages, and none of those costs would be incurred if we had one publicly funded plan in Colorado. I want to go back to the candidate as a former senator and mention that I think one of the important messages for you to get is to become more knowledgeable about what is wrong with our current healthcare financing methods and what our solution of a publicly funded, privately delivered plan would do to solve the problems that we're experiencing right now. My experience as a elected official is you have to learn about so many topics that sometimes it's really hard for you to have enough detailed information about this particular topic. But because it is number one or number two on surveys in Colorado in terms of issues that the public cares about, you as an elected official should be someone who's extremely well informed about healthcare affordability. Maddie, you have your hand up.
Yeah, I'm sorry. I have trouble unmuting on my phone. Yeah, just in terms of one thing that we pulled out from the movie Healing Us, which I know many people in this call have already seen, is an amazing graph that is the usual one we see about the per capita cost of healthcare around the world, but it's broken down showing that we already are paying for healthcare out of taxes the same amount that other countries pay, and all the rest is profit. It's over 100% increase, all profit, not going to healthcare. So I think that's also an important messaging to try to get out.
Absolutely. All right, more questions.
There was a
Kirby,
comment.
do you have more questions?
Yeah, there was a comment by Monica that made some of the points our speakers did. Here it is. Marcia said, considerations to your point one, and this reference employer corporate health care, how folks would come off. Do they actually have cost sharing and portions of their pay withheld pre-tax to contribute to their premiums? Two, are they locked in the job because they feel the benefits are so good because I don't pay anything? Three, are they not getting the wages they feel that should be paid because the corporate employers are not paying raises, et cetera? And because, scoot down here, because of the cost of healthcare they're providing via benefits to the employees. Good points.
Les, you have your hand up.
Yes, I just wondered, I'm a geriatric doc, and I just came into this discussion late, unfortunately, but I'm still trying to find somebody in the nursing home doctor realm, which is a totally private, outrageous ripoff business. Private equity runs rampant, and the poor, hardworking Medicare nursing home doctors who are supposed to be responsible for every toenail that doesn't get clipped and all the other stuff. All they're worried about is regulation, and more ACOs are coming in now, which on the face, they kind of sound like value-driven healthcare. But does anybody here know somebody who really understands the financing of long-term care and why it's such a difficult thing to estimate the cost of in a single payer package?
I think one of the reasons we don't have an answer to your question is because of the way healthcare for long-term care is financed now. In Colorado, we do have a great way of collecting data from the hospitals for the cost of care, but we don't have a way to collect the data for private care, for long-term care, because so much of it is paid for by individuals from their own personal accounts. It doesn't go through a system now. Um, and that is why the Colorado School of Public Health asked us for additional funds to do the analysis and collect some data from the long-term care um, industry so that we would understand how it's financed now, what the real costs are, and what we could expect to pay for long-term care if we include it in a single payer plan. But right now, there's no data collection system in place. And that's what the School of Public Health has to create.
Yeah, I agree. I think you have to go through all of the how much people are paying into the nursing home.
Right.
And that's, I think, are you including that into what people pay out of their pockets once their Medicare runs out?
Yes. Yes.
But I think that information must be available if we could just get into the books of the nursing homes. I don't know if there are propriety laws about that or anything else, but is there anybody who really understands the economics of nursing homes and why we don't have something as simple as a nurse to patient ratio? You know, some nurses get on duty and they got 30 patients in a nursing home. And then as soon as mama's toe looks black, they think she's going to die because they haven't seen a doctor in 30 days and they can't find a nurse. And so they send her to the hospital for $1,000, you know, to say, well, send her to see a vascular surgeon and whenever you can get her in. You know, it's complex, but there's so much data there that it would be nice to know if somebody that is really up to speed on that. But I'm glad I got a chance to add that to the conversation.
Virginia, do you have anything to add?
No, I think you explained it pretty well, Jeannie.
I think that the nursing home facility lobby is very effective in protecting some of that proprietary information. So it's going to be an estimate that the School of Public Health comes up with to help us know what the real cost should be and how feasible it would be for us to pay for that care. What the majority of us, if not all of us, know is that we should be doing that because it is important for everyone to have the care that they need in all of the settings. But unfortunately, Les, Dr. Reitman is pointing out that we're really struggling with even collecting the data to know exactly how to estimate what that cost will actually be.
One last thing, I think New York State has done a lot of work in this area of long-term care, and they've basically come down to the fact that sooner or later, people are going to have to pay a certain amount out of they're going to have a special insurance fund set up by single payer health care to truly cover long-term care, to take it out of the hands of private corporations. But that's not a simple answer, but they've done a lot of research, so I'll look into that.
Wonderful. And Diane, Diane, I know you're on this call or part of this webinar. Do you want to weigh in because of your expertise on Medicaid? Because we do have data about long-term care costs through Medicaid, but not for the general population. So, Diane, if you want to comment on that, I think the group would appreciate hearing from you.
Yeah. Hi, I'm Diane Dunn. I'm a board member for the Colorado Foundation of Universal Healthcare. You can see that on my name tag here. And for 25 years, I worked for Medicaid, and my specialty was long-term care. The reason that my specialty was from long-term care is that when I was a social worker before going to the state, that's what I did is I took care of people to keep them out of nursing facilities and in their own homes. So working with the state, what I found out is, and you'll see my comments in the chat session, that the nursing facility lobby is the toughest lobby I have ever dealt with. So much easier than the Colorado Medical Society, so much easier than Colorado Hospital Association. The nursing facility lobby is so difficult. But a lot of that is because of people thinking, oh, if I'm on Medicare, that covers old age people, and so it must cover me. And what they don't realize is that Medicare covers the first 100 days of a nursing facility care, but only if you've been in the hospital for more than 3 days. And then that's only at an 80% rate, not 100%. And then you're out. If you want to get care in your own home, you have to be bed bound, not homebound, but bed bound. So Medicare does not cover long-term care. So what's the alternative? Well, those of us who've been working all of our lives, we end up spending all of our money trying to stay in a nursing facility or to pay for care to come into our homes. And if you decide, well, I don't want to not leave my house to my kids, well, then that's called a transfer without fair consideration. And you are penalized for 5 years that you cannot get Medicaid. But here's the reality. Medicaid is the payer of last resort, and Medicaid does pay for Medicaid for nursing facility care, as well as for care in the home in a continuum of care. So from the least invasive, I just need to have someone come out and help me take a bath once a week, to I need someone who's here as a hospice worker because I'm getting ready to die. All of those things are covered by Medicaid, but guess what? To be on Medicaid, you have to be very, very poor. And that means no money in the bank and very little income. So we end up spending all of our own money. This is why we asked the School of Public Health to specifically address long-term care. Because I worked at the state, I know that there are data available for us to learn what it costs and what it doesn't cost. Now, it's not going to reflect the entire population, but we can make some guesses. And I think that's what they're going to do. That's part of the model that they're building. I'm really encouraged that they are, in fact, taking this on because it is very important to do. And everybody here, guess what? We're all getting older. And at some point, we will need some help in some way or another. So I hope you all will join us and keep working with us. As I said earlier in the chat, there was a list of all sorts of organizations. Any one of those or all of us could use your help, whether it's your volunteer time or your treasure by, giving us, forego one latte a month. That's enough to keep us going if enough of us do it. So I'm going to stop making my fundraising bid and turn it back to you all.
Diane, thank you so much. It's wonderful that you have that expertise. We really appreciate you. More questions from all of you or comments? All right, well, seeing no other questions from the group, thank you so much for actively participating in our webinar today. We very much appreciate you and all the work that you have done to support our efforts up to now. And we are depending on you to stay with us throughout this effort until we achieve universal health care for everyone in Colorado. And remember, our next webinar will be about moral injury, a Thursday, June 4th at 6 p.m. So be watching for an invitation from us about that webinar as well. Thanks, everyone, and take care.
Thanks for a great discussion.